So I'm going to talk predominantly on complex knee contractures, but flexion contractures. Most of these are syndromes and more relevant for pediatric orthopedics. They are not easy, and we have developed a little bit of strategy for them. And they are quite disabling for these kids. As you can see, for this child with Beals syndrome, it's got a significant influence on gait and expenditure of energy. If it's unilateral, significant problems. If they got pterygia, there's compromise of hygiene, cosmesis as well. They get picked up in school. And if they have forelimb involvement, the upper limb function is also impaired. As you see, there are quite a few of these conditions which we come across in pediatric orthopedics, and we'll show you some of the examples of mine which I've treated over the years. Conventional treatment, the usual serial casting, splinting, physical therapy, and so on, soft tissue releases, osteotomies, femoral shortening, and so on. Of course, ablative surgery sometimes does help as well. Conventional treatment is good for mild deformities and maybe for guided growth. I'm not going to touch on that, anterior guided growth. For moderate to severe deformities, they do recur, especially if they're arthrogrypotic. Pterygia become more difficult. They can be associated with neurovascular complications, skin necrosis, and so on. And when they have multi-limb involvement, you have to have a real good plan how we're going to deal and how we can improve their activities of daily living, give them independence as well. So external fixators are an alternative for these complex ones. You can do gradual, precise correction, controlled rate. You can keep looking at the skin, blood vessels, and so on. You can do simultaneous knee and foot corrections if they're quite complex. Soft tissue and bony combinations, internal and external at the same time sometimes, and allows ambulatory treatment. There is quite a bit of literature. I'm not going to go in details. As you can see, Herzenberg published in 1994, and they also noted rebound phenomenon quite often when you do arthrogryposis or related syndromes. Huang as well at high recurrence rate at 3 to 6 years, and Damson with Ganem actually had 4 recurrences in 3 knees. There are further publications on a similar line, and then we published our initial series with classic Ilizarov. And actually, as you always know, Gamal always has big publication. This is almost something like 50 or 60 odd patients. So we derived a classification for these contractures, which we published. And you can see group 1, where the contractures are with near normal extensor mechanism, and they are generally need gradual joint destruction. Group 2, contractures with extensor mechanism malalignment, and I'll give each of those examples for you as well, and where you do gradual joint destruction followed by open realignment with frame in situ. And the last group is contractures with complex malalignment, staged procedures with frame in situ. And sometimes we have to add other procedures, as I've shown here on this side. As you can see, indirect tibial lengthening to drag the fibula down, arthrodiatesis, distal femoral osteotomies, and so on. So this is an arthrogrypotic, classic contractures with quadriceps aplasia. These are our original series. We try not to do them that way anymore, but I thought I will show you a good example of that. This young lad, as you can see, gradual correction with the classic Ilizarov with some soft tissue releases, quite long time splinting. And this was at 28 months, about 27 to 60. He did have a recurrence, but he went on to play at the Paralympics in the wheelchair rugby. So he did extremely well. He must be 28 or something now. So practical tips, if you're going to do this, you need to do some percutaneous releases, use a Botox. I know you might ask why, but it sort of helps in pain relief to some extent. Always remember, any knee distraction, beware of the posterior subluxation. And there are some tricks with both Ilizarov when you apply hinges as well as with the TSF or hexapod. Knee hinges should be set anterior, therefore, so that the tibia does not sublux posterior as you distract. And for these, where the muscles are at fault, you may need double motors at the back to keep actually distracting. Single motors may bend, or sometimes I use the old-time clickers because they're really solid. And they need long-time splinting. You might be able to add then anterior guided growth so that you can sort of maintain the corrections. So this lad actually was operated previously. They did a distraction of the knee, but probably did not understand what was going on. Nail patella syndrome, the extensor mechanism was on the lateral side. They corrected the knee, but forgot to put the whole quadriceps mechanism to the front. Because if you don't, the quadriceps mechanism now is on the lateral side. It becomes a flexor of the knee. So he went on to have a recurrence, as you can see. And this is how he actually walked into clinic when he first saw me. So we did a staged individual limb, as you can see. Gradual correction, got him straight, got him mobilized. As you can see, he's got a planovalgus foot as well. And then you can see a big scar through the frame. We have set all our pins correctly so that we can do a quadriceps plasty. I used to do originally the single incision quadriceps. Nowadays, I do a 3-incision quadriceps plasty. And that's his end result. He works in a warehouse. He sent me these pictures. Though the knee flexion is not great, but he can walk straight. His quadriceps doesn't get tired, and there is no chance of recurrence. So again, practical steps, the way you construct the frame for your planning for further surgery, wires versus half pins, because that's very important if you want to lift the whole quadriceps anteriorly. Again, use the benefit of soft tissue releases. They might have tibial rotation. You might have to use derotation osteotomies. And when you have to fix knee hinges, you might have to use triple hinges to get the axis correct. When you do second stage, because the frame has been there for some time, you have to have thorough asepsis. We give about 48 hours of antibiotics. You have to achieve full knee extension. You may have to go and do a proximal rectus release if you have to bring the whole patellar mechanism to the front, because now it's the whole quadriceps mechanism is at a shorter length. Distally, for distal realignment, depending on the age, either you'll do, for the mature skeleton, you'll do a full cushion. But if it is a younger child, I'll use either a modification of Gremont. In the olden days, I used to use the modified Roux-Goldthwait. And mobilize the knee after 3 weeks, add removal cast sprays, and then we use dynamic orthosis. So this is the third group, contractures with complex malalignment. She had significant deformities treated elsewhere with the femoral osteotomy. I don't know how well you can see the knee joint, but maybe in the next picture you should be able to see it. She had a very complex, you can see in the arthrogram pictures, the fibula is very high. We did an arthrogram to set the wire and so on. So a stacked classical of frame, 3 levels. Initially tibial lengthening to get the fibula down, and then rest of it to derotate. As you know, when the extensor mechanism is on the lateral side, you get the triple deformity of the knee. So the classic polio deformity of valgus, external rotation, posterior subluxation. So you have to correct all these 3 deformities. So the strategy for this one was indirect tibial lengthening to start with, drag the fibula down, joint distraction, add a distal femoral osteotomy, final realignment with open extensor mechanism realignment with frame in situ. And that was the end result with good extension. She had flexion to about 70 or 75 degrees. We did the other side as well. So again, for this analysis, you need to go back, clinical assessment, evaluate the hip deformities. Quite often they will have a hip fixed flexion deformity. You will have to address the hip flexion when you do your quadriceps plasty, depending on how much you need to release anteriorly through a bikini incision. A stage preoperative plan, intense rehab. You have to really maybe do a bit of rehabilitation if you can. Again, when it comes to some of these conditions, especially when you deal with popliteal pterygia, your sciatic nerve is sitting in the web at the apex. So if you don't realize that, it feels like a cord. So you have to be careful, get the plastic surgeons involved. Initially, we used to get them involved for Z plasties, but I'll show you an example that we have distracted and the pterygium has gradually disappeared. So you can stretch the skin. So it's not only distraction osteogenesis, it's distraction histogenesis. So again, simultaneous, you can now with hexapods, you can do proximal femoral gradual shortening and simultaneous distal joint distraction with stacked frame so that it becomes easy on the knee joint. And I'll show you one of the examples. So this was example later on after the hexapod arrived. You can see the pterygium. and then use your software, stack TSF, and you can see proximally where the arrow mark is, we are doing gradual shortening with simultaneous distraction at the knee joint. And then the end product, as you can see with the red line, you have to get the knee absolutely collinear. And then usually once we've corrected 3 weeks later, we convert to knee hinges, mobilize, and then once we get reasonable range, remove the frame, put it on, put a cast brace as well in addition. This is a case of a child with dystrophic dysplasia at 2 years of age. You can see the patella was not palpable, of course. Also had upper limb deformities and club feet. So had spinal problems too, and previously operated as well elsewhere. So that's what his presentation when he came to us more recently at age of 7, significantly impaired walking and predominantly wheelchair bound. And as you can see, standing views as well as a CT scan is actually patella is quite lateral, and the whole tibia, as you can see, is externally rotated and posteriorly subluxed. So these were all the findings clinically, including bilateral FFT at both the hips. And then we did gradual distraction, again stacked frame with the TSF across the knee joint. We did not want to touch the foot this time. The mom said, we'll just do one joint at a time because of pain and so on. And then we went and did a second stage modified Jude cordyceps plasty 3-incision technique and the distal cordyceps. We just could do the old-time Campbell procedure, VMO advancement, and a rectus snip. And that's his recent sort of images. As you can see, physiotherapy is going on. Becky, who's here, looks after him, and you can see the hip and knee is now flat in his prone position. Ellis von Creveld syndrome, they are quite rare. I've got about 6 of them. It's basically an ectodermal dysplasia. So this child, a long-term patient of mine, had this similar kind of stage procedures. I'll just show a quick example, and you can see where the patella is sitting on the CT scan, completely lateral, and she was struggling to walk and getting tired by the end of the day. Same sort of strategy, first stage. And then for this one, we removed the frame because she was getting fed up, and we did the 3-incision cordyceps plasty and got that knee to be fully flexed. And then for the other side, as you can see, we had to do the other side. The other side, the knee flexion deformity was better, so we decided to do without a frame, and this was the end result. Good cords control on both sides, and you can see both the alignment views and pre-op on that side, as you can see, and final post-op sagittals, so the pre and post, and you can see the final result. So the distal femoral osteotomy was also done in the same sitting with the full Curson procedures to completely realign. So on one side, she's doing well. I think she's got 0 to something like 70 or 80. On the frame side, she still has to catch up. She's around 60 degrees. Additional points, you may need to cross the heel to prevent equinus, use a Botox wherever you need, reduce the tibia initially acutely in the tibial ring construct. So one of the things, if there's a posterior sag, you can, if you're using wires in the tibia, you can use arch tensioning and lift the wire up. Otherwise, you put an anterior tibial pin and you acutely pull the tibial up and realign. So that's the best way to sort of keep that joint in place. And then every time you use the TSF program, you have to say it's posterior so that it keeps coming anterior. So it's because of the way the knee joint is, the posterior contracture will keep pulling the tibia posterior. Yeah. You can get problems when you remove the frame. That was the one which you can see this boy had the pterygium. The pterygium is almost completely stretched out. Unfortunately, in theater, when someone held the foot and lifted up, you can see what happened to the. So I make sure all my fellows hold the thigh every time when you change to cast brace. Yeah. In conclusion, syndromic and arthrogrypotic contractures are difficult to treat due to severity and complexity. You have to expect a rebound phenomenon. You can combine some anterior guided growth at the end. Any complex ones, you have to have a planned strategy every time, stage procedures. And we have a multidisciplinary team, which we prepare them well with them. So it's very important. Again, patient selection and attention to detail. Thank you very much.